Okay, right. So this is the first one of our coffee conversations, and the idea with this is we are combining a kind of case discussion and article review. So what I mean by that is we'll be doing some reviews of articles we've read that we are interested in and we found interesting. So between John, myself, Manoj, Sinjan, we each looked up an article. We read through various journals, found something that was of interest, and we thought we would share those with you. So we'll be presenting an article each, discussing it, and then after that we'll go into some case discussions where we've got people can bring their own cases. Okay, so yes, we got the message. Thanks, Jennifer. That's fine. All right, so CBBS. That's a long time since I've had to watch CBBS. So have fun with that. John, I think let's start between us discussing the papers. Okay. And then are you happy to start us off, or?
Why me? No, you go first. You should lead by example. Lead by example, Fadi. It's not like I'm still writing my notes.
I don't mind. Would you rather I did that?
Yeah, go on.
Okay, all right.
I'll believe you into it.
Okay, then. So let me see if I can share my screen and then go through that with you guys. All right, I'm going to share the screen with the article in mind. There we go. So the article I'm talking about is actually called the injectable platelet-rich fibrin versus hyaluronic acid used with xenograft bovine bone, basically, for alveolar ridge preservation. And it's an RCT, it's a randomized controlled trial, and is by a group in Egypt, in Cairo. I like this paper because obviously ridge preservation is a thing, and it's becoming more mainstream, and more people use it. And it is a very, very useful technique for trying to preserve the ridge width and dimensions if we can't place an implant either immediately or in 4 to 8 weeks period. So with that in mind, it was also of interest to me because we are actually running a randomized controlled trial ourselves with ridge preservation techniques using different materials. Now, most people use either xenografts, particularly bovine bone, or allografts, which is human cadaveric or donated bone, for this kind of procedure. Of course, you can use synthetic material as well, but generally speaking, we're using xenograft. Now, whatever material we use, it tends to be osteoconductive. In other words, it doesn't do anything in terms of inducing the stem cells locally to produce bone, doesn't do anything in terms of osteogenesis. It's just acting as a scaffold. So what these guys have done, I've said they're going to use the xenograft, but they're going to see if using injectable platelet-rich fibrin or hyaluronic acid makes any difference in terms of the bone quality. And I'll talk what they mean by bone quality as we go along. So it was interesting. So the injectable platelet-rich fibrin is basically, it's a kind of a second generation method, and it involves centrifuging again. We can go through the techniques, but in essence, what you get is something that's still in liquid form that you can inject, but it still has the platelets in it. It still has lymphocytes in it with all the growth factors with that, collagens, and you get the three-dimensional fibrin mesh as well. So you're kind of getting best of everything. The hyaluronic acid, also called hyaluronan, is basically an extracellular matrix component, and they tend to be a polymer of disaccharides, so like sugar molecules, multiple repeats of sugar molecule units. So it's a glycosaminoglycans, which is very important in extracellular matrix in terms of lubrication, in terms of support, but also in terms of cell communication. So they do interact with extracellular matrix cells, which means they can affect the cell function and the cell activity. So for those reasons, these guys tested both of them. What they did, they took a group of 36. So it's a randomized controlled trial. 36 is not a huge number because they've divided them into three. 12 in the injectable platelet-rich fibrin, 12 in the hyaluronic acid, and then another 12 control. So the control was just xenograft without adding hyaluronic or platelet-rich fibrin. Okay, so we either had xenograft with injectable platelet-rich fibrin, xenograft with hyaluronic acid, or xenograft with nothing. What they did, they then looked, but they used it in areas 5 to 5 for premolar to premolar, aesthetic zone particularly. They excluded people with any illnesses, so any immunosuppressive conditions, if they're on steroids, diabetics, smokers, if they're pregnant, and so on. So they anything with potential medical issues, they excluded. And it was, I believe it was 20-year-old plus. Number of female to male was nearly the same, almost the same numbers. And they looked at outcomes at preoperative. So they had measurements preoperatively, 4 months after the surgery, and then at 1 year. The surgery and the outcome measures I'll go through now. So what they did in terms of surgical procedure, I'll just go to the pictures for that because it's probably the easiest way. There we go. So they did a traumatic extraction of the roots. Then they used the bone substitute test and control materials right up to the gingival margin. And then they covered that with a graft from the palate. The grafts were cut out using a template to make sure it's exactly the same shape. They were left for 4 months before exposing, which is these pictures here, placing an implant and then closing it. Then the measurements were done at a later stage. So you had the preoperative measurements, which we'll talk about in a minute, 4 months postoperative, and then 1 year for some of them. So the outcome measures they looked at, there were 4 outcome measures. They looked at CBCT, so they measured the width of the alveolar ridge using CBCT preoperatively and at 4 months post-op, just before they placed the implant, so they could justify the CBCTs. And they had 3 measurements. One was right at the crest of the bone, another measurement 3 millimeters from the crest, another measurement 5 millimeters from the crest. So they looked at 3 different areas to look at crestal bone loss as well as the rest of the width differences. So that was pre-op and 4 months. The second outcome measure was looking at the gingival thickness. They looked at gingival thickness preoperatively at 4 months and at 1 year. And they did that at 3 millimeter gingival margin. So 3 millimeters apical to the gingival margin. They used the Williams probe to basically measure the thickness of the gingiva. They also looked at the bone width using calipers. So using this kind of, so here it says you got the Williams probe in image B. They use calipers to measure the clinical width of the ridge, not just with CBCT. And they did that also pre-op 4 months and 1 year. And they did that also at 3 millimeters from the gingival margin. The fourth thing they looked at was histology. So again, at 4 months, when they came to place the implant, they lifted the flap. Before they did anything else, they did a core biopsy. So they trephined the 2.5 millimeter core of bone that wasn't left, and they used that for histology. Now, so basically four outcome measures. For the CBCT, they used particularly kind of reference points to make sure it's standardized. I won't go through the details of it because I'll probably make you fall asleep with that. And then they had, from that standardized measurements, they had at crest of bone at 3 millimeters, 5 millimeters. They measured the width. So that was pre-op. The root is still there. This is post-op after the socket graft has been placed. Now, if we go down to histology as well. So with histology, the method they used was to stain with a normal eosin, hematoxylin eosin stain, but also they used something called the trimason staining. The trimason staining basically gives you a red and blue staining. Red indicates a more mature bone, and you would guess a more mature bone will have more inorganic components, and the blue staining would be less mature bone. So that was one way of seeing the quality of bone. Okay, so how mature is it? In other words, does using these adjuncts to your bone substitutes improve the maturity of bone within 4 months? Do they get develop faster? They also looked at the amount of trabeculation. So the amount of maturity was one from the staining, red meaning more mature, blue meaning less mature. The other one was through trabeculation. If they had very thin trabeculae, that's where disconnected, disjointed, that's immature. If the trabeculae were thicker and well connected, then that would indicate more maturity. Obviously, they looked also histologically at the presence of lamella bone with your Harvesen systems developed as opposed to woven bone, immature woven bone. Indications are, presence of osteocytes in the lacunae and so on. Right, so that's the 4 things they looked at, and the outcomes were fairly interesting. From the CBCTs, they found that actually there was a significant difference in bone width with the CBCTs for hyaluronic acid. So the test group that was with hyaluronic acid ended up with better bone, by better meaning the width, the measured, compared to the injectable PRF, which was better than the control group. So there was clearly a difference between the groups, but hyaluronic acid stood out in terms of bone volume. This is looking at the averages of all the measurements, but looking at the crestal bone width, there was the least amount of crestal bone loss, again with hyaluronic acid, compared to injectable PRF and with the control groups. So it seems the first outcome measure from the CBCT, they got better bone volume, less crestal bone loss with hyaluronic acid compared to IPRF and to controls. Soft tissue thickness was actually shown to be better with injectable PRF. Okay, so there was an increase in soft tissue thickness. Remember, they were measuring this at 3 millimeters from gingival margin at 4 months and 1 year. And that was increased with injectable PRF, whereas with hyaluronic acid and control groups, there was a decrease in soft tissue. So injectable PRF seems to increase the soft tissue. The other ones don't seem to help it. That was the outcome number 2. Outcome number 3 is the clinical width, with the calipers. They measured the width of the arches with the calipers. And again, they found a loss of bone width with injectable PRF compared to hyaluronic acid and control group. So there was more bone loss. Last but not least, the histomorphometric analysis showed that there was a lot more mature bone, a lot more red staining, a lot more thick trabeculae and lamella bone with hyaluronic acid, which was better than control group, and the control group was better than the injectable PRF. Okay, so in summary, out of those 4 outcome measures, their conclusions are that hyaluronic acid improves bone maturity and bone volume when you use it with xenograft, bovine xenograft, whereas the injectable platelet-rich fibrin improves soft tissue thickness, but doesn't do much for the bone. Now, that's, stop sharing now. So that was the essential conclusion with that, which is interesting, which some of it, the kind of injectable PRF didn't surprise me, to be honest with you, because at the moment there's lots of studies on this and there's some disagreement how good it is for bone or not. But as things stand, there is no conclusive evidence that using the platelet rich fibrin or any of these products improves bone quality, bone volume, the speed of bone growth, but it has shown an improvement in the soft tissue healing, reduced scarring and swelling and all that jazz. But this kind of follows that as well. Hyaluronic acid with bone substitute in this kind of scenario is new to me, which is interesting. Now, there is a company which you will all be familiar with, Geishler, who's coming up with a new product called Regen Fast, which also includes hyaluronic acid. Now, we at UCLan will be running a clinical trial together with Colin Burns using actually this Regen Fast material in ridge preservation techniques to see how that looks. So we'll be measuring very similar studies, but what we'll be doing is looking, when we do our biopsy, we'll be looking at the histomorphometric analysis, but we will also do PCR DNA polymerase chain reaction to see the gene transcriptions for bone markers, osteopontin and so on and so forth. So we'll keep you up to date. Anyway, I think I've spoken enough. I shall stop there and take questions. It'd be nice to see some of your faces, guys. So does this new product come with the granules? The Regen Fast, no. So, and the same with this. Good morning, Prof.
Good morning, Fadi.
How are you?
Having listened to you speak for 10, 15 minutes,
my
headache's coming on.
I thought I would get it out of the way before you come on. Anyway, so so these materials are additional adjuncts to your bone substitute. The same with this group that did this research, but also Geishler material, the Regen Fast, it comes as an adjunct. In fact, it is currently being marketed for periodontal treatment and so on, but we think it'd be worth looking at it at this in this scenario as well.
Fadi, can I ask, apologies, how long after the grafting process were the measurements taken?
So for the CBCTs, they were done preoperatively and 4 months post grafting process, post augmentation. For the soft tissue, they were done preoperatively at 3 months and then at 4 months and then at 1 year.
Soft tissue.
For the soft
Why didn't
tissue.
they do the bone? Why didn't they do the bone at 1 year?
They could. Well, they did it with the calipers clinically, which is
that's very scientific, isn't it?
I know it's not good at all. But the CBCT
is that the same instrument as this thing?
It's a bit finer.
You know, since they gave you that PhD, you've got worse.
Here we go. The abuse starts. I missed it. I missed this.
It is interesting. I don't know what John, probably Tom yet. I don't know how much you've done, but I remember being invited to give a talk at ITI, the British leg of it. I think it was in Leeds. Who was the chairman who was in Leeds at the time?
Leeds.
Can't remember his name. Anyway, I gave a talk in Leeds.
I hadn't qualified back then, I don't think.
Really? You want to play this game?
No, I don't. No, it's fine.
Seriously?
He's definitely got more cocky since he got his PhD.
I gave a talk at the ITI in Leeds. This must be 10 years ago, possibly longer, but let's say 10 years ago. and I was on a panel. And believe it or not, and if Manos was here, he'd nod his head sagely. But as you know, I've never been a great advocate or a supporter of the individual additional growth factor into elements of healing, because I believe you need a wider cocktail of it. So I remember being on a panel discussing platelet-rich plasma, not platelet-derived or platelet-rich or enhanced fibrin, but it was platelet-rich plasma. And what was interesting, this is 10 years ago, was the discussion was there was, even then, there's no evidence it does much to bone. Anything platelet-derived doesn't appear to have much of an influence on bone. But as you have pointed out in this paper, even 10 years ago, it was, I say agreed, it was accepted that anything from platelet in terms of a factor, growth or otherwise, would have an augmentative effect on soft tissue healing. And it's interesting, here we are in 24, similar sort of clinical research showing exactly the same outcome. Bone, questionable for reasons I suspect I know, but soft tissue, definitely, it's got some enhanced effect. But what all these clinical trials fail to do, and again, I think this is worth considering when colleagues are faced with people flogging them bits and pieces, is the long-term change. It's the long-term change. Even a year, you could argue, is short-term.
Yeah, no, I agree.
Particularly in the life of something that, like bone and soft tissue, which are living plastic tissues, always changing, always adapting. So I'd ask colleagues just to take that in when they hear these results, because you're getting a very short window of activity.
I think one of the reasons they did, well, I presume the reason they didn't do a 1-year CBCT because they couldn't justify it clinically to do another CT scan. That's one. Secondly, I think if you do a CBCT with the implant in place, you will get some artifacts, and they may have had to do some GBR at the same time as placing. So I presume those are the reasons. Nevertheless, the changes can go on. I think the key thing for me was when we do ridge preservation, we tend to wait, depending who you talk to, anything between 4 months and 6 months, depending how much you trust the material. The key thing is, if we use the ridge preservation techniques, which is well established and is a safe way of doing things for certain circumstances, if we use an adjunct with this, can we improve the bone volume? And I agree that obviously the injectable platelet-rich fibrin doesn't seem to have made any difference there. There was a question there, I think, said, why didn't they place a graft with PRF? I think they didn't explain why, but I presume the injectable platelet-rich factor has already got that and more. So it's PRF plus more. It's got the platelets, it's got the lymphocytes with all the growth factors, and it's got the fibrin mesh. I think that was the thinking. It's got all of that you want from there. Somebody also asked, what is the name of the material? So I'm not here to sell any material. I don't have any commercial benefits, just for the record, but it was RegenFast from Geisler. Tom, you've got your hand up, mate.
Yeah, what I was sort of wondering about, obviously with hyaluronic acid, you've got different levels of cross-linking. The different levels of cross-linking are associated with how much additional weight, they'll increase in volume as they absorb water, and the different values of cross-linkage will affect that. I don't know, it didn't really specify, maybe it does, I didn't really specify like sort of how cross-linked, or that was, how much the absorption rate would impact on the growth. Can you just clarify with the hyaluronic acid one? Obviously it will be absorbing extra water, and that will aid volume, but was there an impact on the bone quality in that case, or did actually the increase in bone volume allow for more osteoblastic activity in that space in between the xenograft? Did it seem to improve quality much And again, just to kind of, not in this paper, but do you think we would see different results with different levels of cross-linkage of the hyaluronic acid?
Thanks, Tom. That's really good question. So hyaluronic acid, obviously, it depends on the formulation and so on. So they don't go into details of it. All they say is the brand they use, but also it was a 1 to 10 kind of mixture between the hyaluronic acid and the bone substitute. In terms of water absorption and so on, yes, absolutely. I think that will probably be a transient effect in this kind of scenario. And because it's in a socket, there will be, and there were intact sockets, there will be limited ability for it to swell, so to speak. But the most interesting, to be honest with you, out of the 4 outcome measures, the one I found most interesting was the histomorphometric analysis, because that's the most quantitative way of doing it from what they've done, and the least subjective, if you like, because they used software that gave you percentages of red and blue, for instance, so you could see how much immature bone you've got. The way they looked at the quality of bone was the thickness of the trabeculae. So, for instance, in the control group, where it was just xenograft, they found trabeculae that were not interconnected. They were thinner. There was lots of material in between them. With the hyaluronic acid, they found thicker trabeculae, which were interconnected, established interconnection. There were more lamellar bone, more Haversian systems. And in fact, which was very surprising to me, they also found less graft material. So not sure where the graft material is gone, because xenograft doesn't resorb that quickly. You know what I mean? So I think what they mean by that, percentage-wise, there was more bone, less of that, compared to the control group or the IPRF. So from this, there is an indication that the quality of bone was better, but quality meaning maturity and volume. But yeah, I agree with. I mean, hyaluronic acid is a glycans. I mean, the glycans, there are some variations in them. So that's another whole set of discussion. How does those preparations affect this? But it's just interesting, because if we take this at face, the numbers are small, by the way. Now, this was a little bit frustrating for me, as I think Prof. Crean knows, is that they used 12 people for each group. And we had this discussion, I think, a month or 2 ago, that these are small numbers, because we've got a study where we've got 17 per group, per test group. And we were told by the powers to be that these were not enough for an RCT. There had to be a pilot study. Anyway, I'm not going to go into that. So it's a small number. Nevertheless, it was statistically significant differences.
I mean, it's a very important point you make. The smaller the group number, the greater the chance that these results are by chance. And you have to have a big number. Certainly, you're talking north of 30, 35 into the 40s before you can begin to rely that chance has less of an impact on these results. It's small numbers means you're almost reading case reports.
Yeah.
And what they titled this a randomized controlled trial, I think, if I'm right, if I just got the beginning of it. However, it doesn't mean you can ignore the results. I like the idea of Tom's, sorry, Tom, where are you, Tom, by the way? Are you in a bloody McDonald's or something?
He's in a pub.
I'm in a cafe.
You're in a cafe.
Yeah.
Well, sorry to interrupt your life, my boy. Could you get me some wine gums from the...
Don't worry, I can log out. It's okay.
No. It's very homely. What was I going to say? I think the idea of the hyaluronic acid, they didn't put forward a reason why, did they? Tom's idea of cross-linking and additional bits. Because, of course, this is ground substance, and ground substance is just a facilitating environment. The matrix, of course, is the key element of what's in that ground substance. What's in there that the cells will connect to. That's the magic. And as you say, Tom, the more cross-links you have, the more water it's going to attract, you know, and you have an easier passage perhaps for transmitters, whatever they are, local chemokines, possibly even hormones, to actually access the cells that we're talking about. That's a really interesting point, which we could easily figure out, I would imagine, by simply, oh, somebody put a CD44 up. I missed that. Let's have a look, chat.
It's a CD44 ligand that can initiate differentiation of osteoblasts. Yeah. Yes, thanks, Hassan. So it does interact with cells, but it also does act as a facilitator for the matrix. And we know extracellular matrix is key for cellular interactions, cellular viability, because if cells can't attach, can't be stable, then they can't remain vital. So they don't go into details of the cross-linking for this. They don't go into details of what they think the mechanism is, other than hyaluronic acid is important for cell interactions and for extracellular matrix. I mean, that's as much as this paper goes, but I guess it is partly what Hassan says, that it does interact with cells directly, but also it can help. If the matrix grows faster, if we get osteoid developing faster, if we get the matrix starting sooner, then by definition we should get faster bone growth, in theory.
I mean, there's no doubt people like me get obsessed, as you know. I am obsessed with the fact that all this graft will have probably changed significantly down the line. But from a clinician's point of view, from your point of view, it probably doesn't matter. The reason you're grafting is to allow an implant to get hold and integrate, regardless of how much bone is around that implant in terms of how much you've grafted with. If that all disappears a year, 2 years, 5 years, 10 years down the line, it doesn't matter, because it's integrated and the biological system will have decided how much bone you need around that implant, not you. And that's the great balance here. This is human beings saying you need this much bone graft, and we haven't consulted nature. And Fadi, you will know I'm a believer in soft tissue perhaps influencing how much hard tissue we can actually end up with, not how much you put in, but how much you end up with. So I guess really for colleagues is to recognize that what you're trying to do is give us a steady enough base for an implant to stand a chance to get integrated. Once it's integrated, let nature and biology look after it.
Yeah. Thank you. I think we've milked this paper enough. Shall we go to the next one?
Can do.
Yeah.
Yeah, sure. Fadi, would you be able to share my paper? Because I'm